Well, good morning, everybody. I want to welcome you to Grand Rounds this morning. We're pleased to welcome back Dr. Robert Gluckman, who's given this talk for, as I understand it, nearly 20 years. Update in outpatient medicine. Dr. Gluckman has been the Chief Medical Officer for Providence Health Plan since 2012. Prior to that, he was on the faculty at Providence St. Vincent for many years, where he was Associate Program Director. He, I was just learning, helped start the first evidence-based medicine curriculum in Portland and has been a champion for value-based care and evidence-based care, primarily in outpatient medicine, for many years. He graduated from the University of Illinois with a medical degree from the University of Chicago in 1982, and he also completed his residency in Chicago. He's a former treasurer for the American College of Physicians and served also as on the Board of Regents for the ACP. He's a well-known national presence, and we're lucky to have him here today for his update in outpatient medicine. Welcome, Dr. Gluckman.
Thank you. Yeah, Jesse, he asked me when I did this talk for the first time at ACP. I told him it was 20 years ago, so I had hair then. But one of the things that's kind of interesting is a lot of the themes that I've been talking about are the same. And so some of those themes will be the same today. The information is different, but some of the challenges and the problems are the same. Getting the consistency of practice, reaching targets, applying the evidence in a systematic way. How do we incorporate patient values? A lot of these themes, trying to create more value, they continue to evolve. And so today we're going to talk about a variety of things, but first I have my disclosures, which were all purchased before people worried about disclosures. And but I don't think there's anything that I'm really talking about today that would be relevant to the manufacturers of those healthcare. I have some stock holdings in those things that I've had for a long time. Do I recommend what? Those stocks. No, I actually have to be honest. Today, I think that healthcare professionals should just not buy healthcare stocks. But I'll sell them when I retire. I don't want to pay the taxes, I'll be honest. All right. This is what we're going to talk about today. It's going to be a significant dose of diabetes. When I gave this talk at the ACP 2 months ago, Liz Stevens wasn't on the program, so I kind of felt like I needed to fill in a little bit. I don't see Liz in the audience today, which is probably a big relief for me, so I won't say anything that she can refute. But we're going to talk thinking a little bit about dose de-escalation in the elderly. There are some guideline changes that I think are new in the last 2 years. Around new agents and some benefits beyond glycemic control. There's an interesting paper that now indicates a broader indication for SGLT2 inhibitors for CHF. Some lipid-lowering papers, a paper on the potential interactions between oral over-the-counter medications and DOACs, and then lastly, a paper about some of the controversy around the American Cancer Society recommendations around colon cancer screening in younger patients. So I thought this was a nice schematic. It was from Diabetes Care, the supplement that comes out every year. It was last year's. They just came out with their new one last week. But as we think about diabetic patients and who might need less stringent control as well as more stringent control, there are some clinical factors. And I think that when I show you this paper next, we're going to see that we sometimes have it backwards. So the patients who maybe would benefit from less stringent control are those who obviously have more risk for hypoglycemia. But we often maybe have a misconception about disease duration. So the longer someone has had diabetes, the more likely they are to have other comorbidities, the more likely they are to have other manifestations of their disease. And the benefits of tighter control after a lot of the horses have left the barn is somewhat less. Obviously, as people are older and as people have more comorbidities, less stringent control may be less risky to them when they don't have the same opportunity for benefit. Same thing about established vascular complications. Again, we don't have that opportunity to prevent some of these things anymore, and tight glycemic control probably puts people at higher risk. And then these issues about patient preference and resources and support systems need to be thought about as the treatment for these diseases has gotten really quite expensive. The first paper I'm going to go over is from JAMA Internal Medicine. It was published last year, and it looks at the use and discontinuation of insulin in a large cohort of patients with type 2 diabetes who are from Kaiser, who were treated in the Northern California region. They were age 75 and over. They were followed for 4 years. And what they did was they assessed the presence of comorbidity and functional status, and then looked at how likely it was that patients had their insulin decreased based on their glycemic control and health status. The baseline insulin use in this cohort was 19%, and the mean duration of insulin use was about 8 years. I think I show this slide because I think sometimes it's kind of useful to think about how do we define people who might be in poor health, intermediate health, or good health. Obviously, a lot of it's just what they look like just across the exam room. But with the Kaiser cohort and with the American Diabetes Guideline health status definitions, there's a lot of similarities. About half of the cohort was defined as being in good health. Good health were people who had 0 to 1 comorbidity, or if they had 2 comorbidities but exercised at least weekly. Intermediate health were patients who had 2 comorbidities but didn't exercise at all, so fairly sedentary, if they had more than 2 comorbidities, or anybody that used a walker. And poor health was any indicator of end-stage disease, oxygen use, cancer, advanced CKD, stage 5, hemodialysis, dementia. And then they looked in the 4-year period, what were the mortality rates for those cohorts, and you can obviously see that in the intermediate and poor health cohort, the mortality was higher. And then, what they did was they said, okay, how likely was it that insulin was discontinued or insulin was used based on the level of glycemic control and the health status? And what you can kind of see here is that the patients who were least likely to get their insulin discontinued when their hemoglobins were less than 7 were the patients in the poorest health, which really should be just the opposite of what we should be doing, because once patients are in poor health and they have tight control, there's an opportunity to back off. And that flowed through across all of the levels of glycemic control. The patients who had the most comorbidities were the least likely to have their insulin tapered. And these patients who have tight control or are in poor health probably are at more risk for with their insulin than benefit. And there was also a paucity of the opportunities to simplify their insulin regimens. So the take home here is that current guidelines would recommend that we individualize glycemic targets based on health status. This cohort demonstrated a greater use of insulin in patients with poor health status. And the cohort also demonstrated less discontinuation of insulin in those with tight control and poor health status. I think a lot of you are aware of how costly insulin is today. The prices have gone up quite a bit, and they carry the risk of hypoglycemia in the elderly. And so there's really an opportunity for us not to be mired in clinical inertia, but take the opportunity, maybe at an annual wellness visit or some other visit, to say, is it an opportunity for us to de-intensify therapy in some of our patients? The next paper I'm going to present is also, it's from JAMA, also last year. And it was a paper that described the opportunity about switching people from the insulin analogs to human insulin. Over 80% of the insulin use in our population is using the insulin analogs, like insulin glargine and the others. Human insulin costs half as much. If you get your human insulin at Walmart, it costs 10% as much. And many of the patients who are type 2 diabetics, who don't have frequent hypoglycemia, can be safely switched from a very costly insulin analog to an insulin product that would be 10% to 50% as much. So in this cohort, over 14,000 patients managed by CareMore, is a managed care organization in Southern California. This was on their Medicare Advantage population. They identified ideal candidates as being those who used 2 or more insulin injections a day, who were receiving basal and prandial injections, who were on a significant amount of insulin, because that's where the savings would be, 50 units or more. If they had a history of non-adherence, because there's a suspicion that when patients are not adherent to insulin, one factor may be the cost. And then they didn't do this switch on patients who had recurrent hypoglycemia, because those patients, and type 2 diabetes, I'm not talking about type 1s here, and I'm not talking about anybody on a pump. I'm just talking about type 2s who get more than 2 injections a day. There is some benefit in a longer-acting insulin in those who have demonstrated recurrent hypoglycemia, but that isn't all that common. The way they transferred patients to human insulin was they recommended an initial dose that was 80% of the total, and they could give it either as a 70-30 or NPH, and they split it 2/3 before breakfast and 1/3 before dinner. And here are their results. When they started this program, only about 15% of patients were on human insulin, 85% of the patients were on insulin analogs, implemented the program, and then after a period of stabilization, you had about 65% of the patients getting human insulin, and about 35% of the patients across the entire cohort, even the ones they didn't switch, were on analog insulins. And if you look at the costs, this kind of correlates with when the price of insulin started to increase so dramatically. If this would be extended beyond 2015, I'd be off the chart here, because the price of insulin analogs has continued to go up exponentially. But what you can see is that the expenditure on insulin analogs dropped very substantially. The expenditure on human insulin increased. Total expenditure dropped to less than half of what it currently was. Now, I think that it's time for us to take a look at some of this, because many of the patients with type 2 diabetes, as I'm about to show you, would benefit from newer agents, which are also expensive. So in order for us, from a population-based approach, to get the most benefit for our patients who have type 2 diabetes, and we do need to be giving many of these people, newer agents, one way to help pay for that is to stop using the expensive insulin analogs when they're not really necessary. And that's how we can have some of the resources that we would need to best take care of people. Now, what happened to them on a clinical basis? This is looking at their hemoglobin A1C. The increase this was a Medicare population, was minimal, likely not clinically significant. There was no increase in hypoglycemic or hyperglycemic events, and there was no evidence of a mortality worsening. In fact, there was a non-statistically significant increase in mortality in the non-switch group, but likely confounding, not because insulin analogs are harmful. That's not my point. My point is that you can do this safely without any real meaningful impact on reducing glycemic control or increasing adverse events. I thought this was an interesting paper. It was published in the summer online, so it's probably in the fall in the print edition. This is if you really want to take a look at it. But it really kind of emphasized the benefits of lifestyle modification on a consistent basis. The problem I think that I'm going to raise is how can we do this in an organized way? But this was a real world study from 2 large Boston academic centers, almost 20,000 patients, where they looked at the frequency of the electronic health records documentation of lifestyle issues, diet, exercise, or weight loss counseling. They did it using natural language processing. And they assessed the treatment for 2 years after the cohort entry, and then they looked at the follow-up period for what happened to these patients for a mean period of over 5 years. And their outcome was the time to the first cardiovascular event. And what they found was that if people had regular and frequent communication as reminders around diet, exercise, and weight loss, their hemoglobin A1C dropped 1.8%, which, by the way, is more than for any of the newer drugs that I'm about to show you. And then if they had less frequent counseling on dietary and lifestyle modification, their hemoglobin A1C dropped less. And more interestingly is what would happen to them in terms of cardiovascular events. So there's a substantial difference in patients who had frequent reminders about lifestyle modification on a monthly basis rather than less frequently. The absolute risk reduction at 10 years was 5%. The number needed to treat was 20. So, the question, of course, now is how can we do this? Because, reaching out to somebody and talking to them on the phone on a monthly basis is pretty resource intensive. So just hypothesizing here, we're moving into a time when we're able to have much more technology interact with our patients. Whether we do this through MyChart, which is easily accessible to any of our physicians who are taking care of people on the Epic system. But there's also technology tools. There's a burgeoning industry around here that we're frequently interacting with patients and sending them reminders. There's an opportunity for group visits. But I think that leveraging some of those things is something we shouldn't lose sight of as we also think about some of the medications people need. The new diabetes care supplement just was published last week. There's a few items I just kind of wanted to highlight on the newer agents that I think are important to emphasize. The first one here that was different is that when it comes time to think about an injectable agent, and type 2 diabetics, the ADA now recommends that we think about GLP-1 agonists instead of insulin as the first choice in someone who cannot be controlled any longer on an oral agent. There's some exceptions, and that exception might be when their hemoglobin A1C is above 11%, or when patients have kind of catabolic impact from their level of hyperglycemia and severe symptomatic hyperglycemia. But in the absence of those, GLP-1 agonists are preferred over insulin for patients with type 2 diabetes. Next, grade A recommendation is that if patients have significant comorbidities with cardiovascular disease, chronic kidney disease, or CHF, that an SGLT2 inhibitor or GLP-1 receptor agonist are recommended. I think that as I show you later in a paper, if patients have heart failure, it's kind of more compelling for an SGLT2 inhibitor. That's a grade A recommendation, and that level of evidence increased from a B to an A in the last year. Something here that I think, when I still precept in the St. Vincent Clinic that I founded once a month, and one of the things that I think I regularly observe is the level of the slowness of the pace of intensification of therapy. I think this is generalizable to a lot of different conditions, not just diabetes, whether somebody's got hypertension out of control, how do we intensify the therapy for depression, et cetera. So, I thought I wanted to highlight this, that the intensification of treatment with type 2 diabetes not meeting treatment goals should not be delayed. We should be really harping on this and getting things to target a little bit more quickly than we otherwise might, and the medication regimen and adherence should be reevaluated at a minimum every 6 months, otherwise every 3 months. And I think that that's expert opinion, but I did want to take the opportunity for getting people to think about when someone's not doing as well as we might want them to be doing, we need regular follow-up, more intense efforts to control people more quickly. This paper was from the end of 2018. It's from JAMA Network Open. And I thought it was a little bit interesting and provocative, and kind of speaks to maybe the need to think about some of the newer agents in people who are at high risk. Very large cohort, 132,000 folks. It's from a commercially insured and Medicare Advantage database, patients who have type 2 diabetes who were starting on second-line anti-diabetic medication, whether or not they were on metformin. This is the time period that the study was performed. A small percentage of the patients had a history of cardiovascular disease, so these weren't particularly high-risk patients. The primary outcome was based on the time to a first cardiac event, and the first cardiac event was defined as a hospitalization for coronary disease, CHF, stroke, or peripheral artery disease. The results were adjusted for baseline conditions the best they could, so there may be some confounding variables that are not accounted for. But it basically showed that in a pretty short time frame, you're talking about 2 years here, the incidence of cardiac events was greatest on the patients who started on insulin, next greatest on the patients who started on sulfonylurea, and then pretty similar but lower on some of these newer agents, especially the SGLT2 inhibitors and the GLP-1 agonists had the lowest. So even in a short time period, these seem to have some benefits for patients. And they're expensive, but they're really not any more expensive than insulin now, unless you're using human insulin, at Walmart especially, because they have the Reliant brand and it's 10% of the cost. But a sulfonylurea is very, inexpensive, and very low-risk patients would be a reasonable thing to offer for second-line treatment. But otherwise, we probably should be thinking about some of the newer agents. I chose this paper from Lancet because it's the first oral GLP-1 agonist just been approved by the FDA. I checked with our from the health plan, from Providence Health Plan, I checked with our pharmacy department. It's on formulary as of March 1st, so not yet, but very soon. There will be the first oral GLP-1 agonist. And so this was a randomized controlled trial looking at oral semaglutide versus subcutaneous liraglutide, both GLP-1 agonists. Over 700 patients, moderately uncontrolled disease on a stable dose of metformin with or without an SGLT2 inhibitor. They did exclude patients who had chronic kidney disease, proliferative retinopathy, pancreatitis, and then if they were on non-protocol diabetes, obesity meds. I think it's important to know how to titrate the medication and how to start it, because I just talked about intensification of therapy, but if you titrate this medication too quickly, the patient's going to get sick. I just saw a patient in clinic last week who was probably needed to be started on insulin, but in an emergency room setting wasn't ready, so they started on metformin, but her sugars were so high they told her to ramp it up very quickly. So we all know what happened. She started vomiting, GI intolerance, and stopped taking it. So I think it's important that you know how to ramp the medication up. At 3 milligrams for 4 weeks, we would not expect a glycemic lowering effect. So that would be, but that's how you have to start it. Then it's 7 milligrams for 4 weeks, and then it's 14 milligrams. So you have to ramp it up. It takes a little bit of time. The patient has to know that they have to take it fasting with a modest amount of water. There's no food or beverage for at least 30 minutes, as food impairs the absorption of oral semaglutide. So they've got to be able to be compliant with that. We need to make sure they understand how to do that. And then the change in primary outcome was a change in hemoglobin A1C at 26 weeks, but they also looked at the outcomes at a year, and change in fasting blood sugar, weight loss of 5% or 10%, the proportion of patients who reached a hemoglobin A1C target is 7%. So the green is placebo. The blue is the oral semaglutide. So you, obviously, as I mentioned, because they're getting titrated up, you're not getting the level of glycemic control, but eventually they start to do a little bit better than the sub-Q. So they're able to maintain adherence despite the fact that they have to take it with those instructions, but it's still better than giving themselves a shot. If you look at the average amount of glycemic control at 26 weeks, minus 1.2%, persistent, slight decline in the sub-Q amount that's closer to 1%. If you look at the patients who reach target, a little over 2/3, about 60% at a year, but also slightly better than the subcutaneous products. And then there seem to be more effective for weight loss. This is showing the change in weight. So about at a year, about 10 pounds. The percentage of people who met 10% of body fat loss, I think it was around 20% in this trial. But you can see that more weight loss in this with the oral therapy. So to kind of sum up here, the oral semaglutide is more effective than subcutaneous at lowering hemoglobin A1C in a year. It's more effective than subcutaneous at 26 weeks and 52 weeks for weight loss. It's important to instruct patients how to take the medication correctly. The side effects, GI, not insignificant, nasopharyngitis, 14%. But the rate of discontinuation, it's about 11% with the oral therapy. It's 9% with subcutaneous, and obviously smaller with placebo. As I mentioned, for the guidelines, they talk about choosing between an SGLT2 inhibitor or a GLP-1. So I thought I would show this trial that looked at the relative effectiveness of a GLP-1 agonist versus an SGLT2 inhibitor. So this is a randomized controlled trial, almost 800 patients with type 2 diabetes. They were already on metformin, and they were randomized to the subcutaneous form of semaglutide once weekly versus canagliflozin, one of the SGLT2 inhibitors once a day. Primary endpoint was a change in hemoglobin A1C at 52 weeks, and the secondary endpoint was change in body weight. And the GLP-1 agonists do lower hemoglobin A1C about a half a point more than the SGLT2 inhibitors, and they do promote more weight loss. So, but I will tell you that that the SGLT2 inhibitors are about half the cost of a GLP-1 agonist. So it just depends on how much glycemic control your patient needs, I think. And then I think there's also this more compelling case to use an SGLT2 inhibitor in the presence of heart failure or someone who's extremely high risk for heart failure, because the evidence is a little stronger in heart failure patients for the SGLT2 inhibitors. If you need more glycemic control, then the GLP-1 agonists have that benefit. So the percentage of patients with the the subcutaneous semaglutide, the GLP-1 agonist, about 2/3, similar to the paper I just showed you, versus 45%. A little tighter control, you can see, again, a little more benefit to GLP-1. This is the paper that had the 22%, 10% weight loss. So a little more effective for weight loss, more discontinuation of treatment. These are very well the SGLT2 inhibitors are fairly well tolerated drugs, so they have low rates of discontinuation of treatment. So to kind of sum up this section on diabetes, the oral semaglutide is now approved by the FDA. It'll be on the Providence formulary March 1st. It may be on some of your other formularies now. It may be on some of your other formularies a little later, but it's here, it's coming. It's pretty expensive. I don't know what the final post-rebate cost is going to be, but I don't think it's going to be that much different than the GLP-1 agonist injectable, which is probably around $500 to $600 a month, as opposed to the SGLT2 inhibitors, which are probably $250 to $300 a month, just to give you some framework. I just want to remind people that if they have patients who don't have frequent hypoglycemia, they're on insulin, they're type 2 diabetics, they're not on a pump, that you can cut their insulin costs substantially by switching them to human insulin, and safe and effective. I mentioned the SGLT2 inhibitors and lower risk but less impact on glycemic control. And then we shouldn't completely throw away the sulfonylureas. They do have a lot of cost benefits. There may be some increased risk for cardiovascular events. Glimepiride has somewhat less, but they don't have some of the proven benefits of preventing cardiac events. So in the patients who are at higher risk, I think that the newer agents do have a benefit. This paper was published maybe 2 months ago. It's in the New England Journal of Medicine, and it's a paper on SGLT2 inhibitors in heart failure, whether or not the patients had diabetes. It turns out 45% of the patients in the trial did have diabetes or developed it during the trial. But 55% of the patients did not have diabetes, and the benefits were in both cohorts. So almost 5,000 patients, class 2 to 4 heart failure, ejection fraction less than 40%, so it's just low EF patients. This trial did not include patients with persistent ejection fraction. There is another paper that looked at women with persistent, normal ejection fractions in heart failure, and the SGLT2 inhibitors didn't offer any benefit. So it's really restricted to patients with low EF. Primary outcome, worsening heart failure, or there should be or not of, or CV death. And worsening heart failure was defined as a hospitalization or an urgent visit with IV therapy. So, these would be patients who were then admitted under observation or seen in the emergency room and given some therapy. And then they had a secondary outcome that looked at symptom scores using a standardized tool called the Kansas City Cardiomyopathy Questionnaire. Very, very short follow-up, 18.2 months. So what did we see? We saw a significant decline in the primary outcome, which was cardiovascular, a CHF episode that needed treatment versus plus a cardiovascular death, and the number needed to treat is 21. If we looked at all-cause mortality, that also had a benefit, and you can see the benefits come on reasonably soon, within months, and the number needed to treat was 43, and there's no difference in adverse events. In this trial, I should mention that there was patients were on appropriate standard therapy, very high use of an ACE inhibitor and ARB. Only 10% of the patients were on Entresto. Sorry to use the brand name, I just can't remember the generic name, but the neprilysin inhibitor combined with the ARB. And then a significant percentage of the patients were also on spironolactone. So they also had a device when a device was indicated. So the baseline therapy was at guideline-based therapy, so this was in addition. The benefits were in addition to that. So now I'm going to move on to some thoughts about lipid lowering. This is a paper from JAMA Cardiology last year. It looked at the impact of adding ezetimibe to simvastatin compared to simvastatin monotherapy after an acute coronary event in patients who were over the age of 75. And I thought this was a pretty interesting paper as well. Over 18,000 patients, they were all randomized within 10 days of acute coronary syndrome to simvastatin monotherapy versus simvastatin with ezetimibe, which is, again, like I say, is now generic and inexpensive. These were the criteria. If they weren't on any previous lipid lowering, the LDL could be up to 125. If they were on a statin, they were all patients with an LDL of 50 to 100. The primary endpoint, as in most cardiovascular trials, this basket of outcomes that would be a cardiovascular death or a cardiovascular event defined as a non-fatal MI, unstable angina leading to hospitalization, revascularization, 30 days after the index acute coronary syndrome or a non-fatal CVA. And the slide maybe doesn't project quite as well, but here's the thing I really wanted to kind of emphasize. You can see that the rate of the composite endpoint, this is 84 months, so 7 years, but you can see when this starts to spread. And really where the spread is, really for the most part, is in patients over the age of 75. So I think we have sometimes we're biased about what do we do about people who are much older in their 70s, late 70s, 80s, maybe even late 80s, when they already have cardiovascular disease. If their patients are still at home and they're still ambulatory and they're functional, these are the patients that need the most intense efforts, not the least intense efforts. And what you can see here is the number needed to treat if patients were 75 or over of adding ezetimibe to a statin. Now, granted, the statin was simvastatin, somewhat less potent than atorvastatin or rosuvastatin. But if patients' LDLs are still, not super low, there's still benefit. And the number needed to treat of 11 for a generic drug, this is probably cost saving, but it certainly has an impact on people. You can imagine, you're looking at an absolute risk reduction of 10%, and even in a short term, you're looking at a significant absolute risk reduction. This was a number needed to treat if they were younger, much less. And again, if you're looking at cardiovascular death, MI, or stroke, again, you start to see spread here, pretty early, and the highest benefits, the greatest benefits are in the patients who are older. So let's not have ageism. Let's not just say, there's less we can do. These are the patients who may benefit the most from a more intense medication regimen. This looks at the association between continuous age and outcome assigned by treatment. Older is when you really see the benefits the most. Also, whether they were older or younger, the benefits were in the patients who had the highest risk scores based on their TIMI score. So highest risk patients most benefit for more intense cardiovascular lipid lowering with a generic drug. I did want to mention something about the PCSK9 inhibitors. This is a secondary analysis of the Fourier trial, which looked at evolocumab. I mention this because how many times has a drug maker actually reduced the unit cost of their drug by 60%? They did. You know, it came out, when it first came out, it was 14.5. Now it's 5,500. It's not cheap, but they lowered the price 60%. And you know why they did that? It's because nobody was prescribing it because it was too darn expensive. So the market can sometimes work. But what I do want to show is the benefits. And again, in the highest risk patients, this is probably cost-effective therapy. So over 27,000 patients, this age range, prior cardiovascular event, MI, CVA, peripheral vascular disease. Their LDLs needed to be above 70 while taking an optimized statin regimen. 69% were on a high-dose statin. Very few of these patients were on ezetimibe. So I think you could put them on ezetimibe first because it's a generic drug, you know, and I think we underuse it for the patients whose LDLs are still, you know, in the previous trial I showed you 50, but you know, in the case of the Fourier trial, 70. This is still subcutaneous therapy. They could be given 140 milligrams every 2 weeks or 420 milligrams monthly. Primary endpoint was this composite of, you know, death, MI, CVA, hospitalization for unstable angina. And the secondary endpoint was the above minus the unstable angina. So if we wanted to look at harder endpoints, pretty short follow-up. And one of the things that they did in this trial that was kind of interesting is they didn't look at just the prevention of the first event, but they looked at the prevention of multiple events. So they're looking at the total event, the total number of events prevented. So there was some lowering of event, about 18% in the reduction of total events. A little less on the first events because, you know, this kind of gives you a nice way of looking at this table. Almost 90% of the trial patients had no events. 5.7 had single events. 3.5% had 2 events. Some people had 3 or more events. And when you look at the total number of events, you're actually, you know, reducing the events by 20%. But there's a lot of not just preventing the first, there's preventing the second and the third. And looking at which events were prevented, you can see that a big component of it is the cardiovascular revascularization, but there are also prevention of myocardial infarction, stroke, and the like. So for every 1,000 patients that were treated for 3 years, there were 22 first events prevented, but there were 52 total events prevented. So probably fits now into something that's cost effective, but still isn't inexpensive. This is from the same volume of the JAMA Cardiology paper. It looked at cost effectiveness ratios where they updated it due to the reduction in the price. So as I mentioned, the patients had to have very high risk ACCVD. The LDL was greater than 70 despite maximally tolerated statin therapy. And they had some analyses based on what the event rates were. So in the Fourier trial, it was a relatively lower event rate. If you look at registry data on how frequently people get secondary cardiac events in clinical practice, it's higher. And then this is these very high risk patients where the event rates are actually higher yet. So these would be patients who still have maybe very persistent high cholesterol despite treatment. Maybe they're still smoking. They've got coexisting diabetes and chronic kidney disease. And so on this handout, I just put the ACA, American Heart Association guidelines on very high risk criteria again. So I would tend to think about this in the patients who had multiple events for sure. You know, patients who had more than one cardiac event, they're going to be at higher rate, higher risk. And if they have some of these other conditions. And then this kind of shows you what the incremental cost effectiveness ratio is. So in the Fourier trial, still $90,000 per quality. But when you get into these patients who baseline risk may be much higher because they have a bunch of cumulative high risk conditions, you're really getting down to, you know, I think it was $10,000, $9,000 per quality adjusted life year. So again, as I said before, in these older patients, think about ezetimibe. Patients who have multiple risk factors, have had multiple events, who still have persistently elevated cholesterol, there is a place for the PCSK9 inhibitors. I think that's kind of what my slide here has to say. And then I thought this was also a pretty provocative paper about thinking about the benefits of primary prevention, where they did a microsimulation model on four scenarios. Patients who had a 10-year risk of greater than 7.5%, or diabetes, or an LDL greater than 190. Patients who had a 10-year absolute risk using the ACC calculator, 5 to 7.4% with this LDL cholesterol above 160, or patients with a 10-year absolute risk in that more modest range also with a lower baseline cholesterol, or treating everybody with a greater than 5% risk. And they model treatment with a moderate intensity statin for borderline risk patients and high intensity statin for the higher risk patients. And they did this modeling on 100 simulated cohorts of over 1 million patients. And you know, it's kind of a complicated slide, but you know, green means it's cost saving with this intense green. These are the cost effectiveness ratios, which are all pretty low. Even in this, if patients have elevated cholesterols, even in this is men 50, men 60. So again, modestly elevated cholesterols, probably cost saving. Women a little less so. But it makes this decision around primary prevention, I think, a little bit more complicated. You know, and this is where patient preference and patient value, you know, patient's own values about how much they want to take a pill every day comes into play. Some people are not going to be too interested in taking a pill. Some people might want to really reduce their cardiovascular risks more, and it's still the largest contributor to morbidity and mortality in the country. So I thought this was kind of interesting because they are very inexpensive drugs now. They're all generic. They're all about $5 a month. And for the patients who have elevated cholesterols and significant elevations in cholesterol, these are, you know, cost saving because the event's prevented. And in modest elevations in cholesterol, these are really at minimal cost. So it just depends on the value system of your patients, but I thought it was interesting to talk about and to maybe think about, now granted, there's concerns about does it really increase diabetes? You know, those are small factors compared to potential benefits. So I tend to think that it's worth talking about with many of our patients. So kind of sum up the lipid-lowering paper here. Treating patients with borderline risk and LDL greater than 160 is likely cost-saving. Treating patients with borderline risk and LDL 130 to 159 may be cost-saving in men and likely cost-effective in women. The paper, by the way, the simulation model only assumed 50% adherence. They did assume 0.5% per year development in diabetes. You have to have a long-term horizon in thinking about cost savings to develop. I added this in here. Coronary artery calcium score is now covered. Patients that are on the fence might think about whether or not they want a coronary artery calcium score to see if they want to take a pill every day. Full disclosure, my dad died at 54 of a heart attack, and when I remarried, I gained a little weight, and my LDL went up, and I got a coronary calcium score. It came back 1. I decided not to take a statin. So I just tell that personal anecdote so you can see how you might use that. I think you need a patient-centered approach. And instead, I've lost 20 pounds and my LDL dropped and I'm off a statin. So, all right, I'm going to add, wanted to mention this paper. I think I use this as a platform to really talk about the importance of really understanding what our patients are doing from over-the-counter medications. So this was a paper from the Journal of the American Geriatric Society. They surveyed patients who were treated with a direct oral anticoagulant at UCLA and UCSF. So kind of a West Coast patient population. We know we have a lot of people who use a lot of over-the-counter stuff here as well. That's why I chose it. Patients who were on a DOAC, 34% of them reported daily or almost daily use of at least one oral over-the-counter product that has a potential interaction with the DOAC. 27% of additional patients reported some use, not daily use, but some use. And here's some of the things that were reported about, you know, whether it be herbal teas, turmeric, ginger, Chinese herbs, ginkgo, not that much St. John's wort anymore, a lot of aspirin use, some NSAID use. And And the point I kind of want to make here is that, especially on some of these other things that people are taking, we don't know what the interactions might be. But when someone's on a direct oral anticoagulant, we do know that there's less bleeding risk than with warfarin, but there's still bleeding risk, and those bleeding events could be catastrophic for people. So if they're taking things that we don't know what their impact might be on their interaction, and there isn't really a medically necessary reason to take them, it might open up the opportunity to say, look, I'm giving you this medication to prevent stroke, because most of the patients who are on a DOAC, either it's short-term use after a procedure that puts them at risk for DVT, or it's long-term use to prevent a stroke with atrial fibrillation, and say, why would they take an over-the-counter medication or an over-the-counter product where they don't know what the interaction would be? It could be potentially dangerous, and I think it's worth raising with folks when they go over their medication lists. In this paper, they showed that the knowledge of taking aspirin and Apixaban was correct in quite a few patients, but was incorrect or uncertain in many others, and the knowledge base around an NSAID and Apixaban was actually not all that common. So I think that I wanted to use this as a reminder of really being sure that we're aware of what people are taking on a over-the-counter basis, and then if they're on a medication that puts them at some risk, we can use that as a platform to maybe have people take off some of the medications that may not be of benefit to them. And then the last paper I'm going to talk about today is on colorectal cancer screening. I get these questions quite a bit about what to do about the American Cancer Society's recommendation that screening should start at age 45 instead of at age 50. And I think it opens up a can of worms in primary care for a number of reasons, and I thought I'd share some things. So first of all, when the American Cancer Society, they did this with their breast cancer guideline, and they did this with their colon cancer guideline here, is they classified their recommendations as either strong or qualified. So strong means you really should do this, and qualified means, well, some patients may want it and some patients may not. And that's where mammography in 40 to 44 became qualified with the ACS, and it's where the colorectal cancer screening between 45 and 49 comes in. At 50, it's strong. The recommendation was either for a stool-based or a structural test, and the basis for the recommendation was that the incidence of colorectal cancer in younger patients was starting to increase. And I just kind of want to point out the dramatic decrease in colorectal cancer incidence in this older population as a result of screening. So it just really kind of speaks to how effective screening has been in reducing the incidence of colorectal cancer. But I think it's still important to recognize this is kind of a logarithmic, axis here. So the incidence between 45 and 49 is still about half of what it is at age 50. It may be increasing, but the incidence is still relatively is much lower. Now, this was a paper from the Annals of Internal Medicine that kind of was a counterpoint to this recommendation. Kind of shows a few things here. This here is the incidence rate of colorectal cancer. So kind of shows that the incidence overall is increasing, but the mortality rate has not, and that the amount of screening has gone up. So it doesn't really show any mortality rate increase. And the other thing that I think this might be from a different publication, but this was from the American Cancer Society paper. It was modeling the life years gained based on the modality of screening. So the life years gained, if you started screening at age 45 versus at age 50, so it does show a little bit of uptick. But the other thing I really kind of wanted to point out here is that the amount of life years gained between FIT and colonoscopy is relatively small. It's 16 per 1,000 patients screened. Now, one of the other benefits with colonoscopy as a screening mechanism is polyp removal and the prevention of developing colorectal cancer. So that also would have impact on people, that they wouldn't have colorectal cancer, wouldn't have to have their portion of their colon taken out. So I'm not saying that FIT first is the best thing for everybody. I also kind of wanted to point out, this is the multi-targeted stool DNA test marketed under Cologuard, the little happy figurine on all your commercials. And in the life years gained, estimates are actually lower than they are for FIT, despite the fact that it costs 40 times as much. So I think if we're going to screen, the question is colonoscopy versus FIT. And in this 45 to 49-year group, I kind of really wanted to make sure people were aware the patient is going to have to pay a lot of money for that colonoscopy. If you're 50 and over, it's covered under a preventive mandate by the Affordable Care Act. So the Affordable Care Act definition of what is a zero cost share to the patient is a U.S. Preventive Task Force Service recommendation that's A or B. The U.S. Preventive Task Force Service recommendation for colorectal cancer screening starts at age 50. So at 45 to 49, the patient has to pay. And so they're going to pay $2,000 to $3,000 for a colonoscopy, and a FIT test is going to cost like $25, not 25. So my take-home points here are: you could consider colorectal cancer screening in a younger population, but it is still about half the rate at age 50. So this is for average risk people, by the way. We're not talking about people who have first-degree relatives with colorectal cancer or first-degree relatives of polyps at a younger age. I wanted to kind of underscore that the most important thing to take away from this is that actually colorectal cancer screening is so effective, and we really should be getting our patients screened. It's probably the most effective of the cancer screening modalities out there. And we still run 20 to 30% of patients who don't get any screening test at all. So the best test is the one the patient will do. I think it's important to recognize that the full coverage where there's zero cost share to the member for colonoscopy really doesn't start until age 50. So it's going to be costly to them if they choose a colonoscopy, if you recommend one, whereas FIT, fecal immunochemical testing is going to be pretty cheap. Doesn't really offer the opportunity to reduce colorectal cancer incidence, but at age 50, if they get colonoscopy, you have that opportunity. And then this, from the Annals paper, they just looked at what's the cost of universal screening with a mix of colonoscopy at FIT starting at 45. And if they estimated at $250 per screen, which means that most of the patients are getting FIT, and it was $5.5 billion or $6.1 million per death averted. So pretty costly to start colonoscopy, plus the resource use, the workforce requirements to start colonoscopy at age 45 would be pretty challenging. But patients who are particularly concerned about this may opt for a stool-based test. And then lastly, this is a paper that looks at the potential for the interval in patients who have a non-advanced adenoma. Just to remind you, a non-advanced adenoma is less than a centimeter, and fewer than 3. So if a patient has 1 or 2 adenomas that are less than a centimeter, that's considered non-advanced. And in this follow-up study of 3 large cohorts, 123,000 patients, could find no benefit in reducing colorectal cancer rates if they had their interval screening at 5 years rather than 10. So for patients who have low-risk adenomas, they should be screened and follow up just as if they had no adenoma at all. It's my understanding that in March, the journal Gastroenterology is going to publish a new guideline. I don't know what it's going to say, but I hope it actually says this, so then people kind of know that if they have a small adenoma, 1 or 2 small adenomas, they can wait 10 years instead of 5 years. And we'll see. Next year, I'll have that guideline in the talk. So we have some time for questions. Any questions? Yeah.
I was curious about the Improve It trial. Why did they use simvastatin? Why did they use a moderate intensity statin instead of a high intensity statin?
Yeah. So the question was, why did they use a moderate intensity statin rather than a high intensity statin in that trial? Well, the trial was started before some of the benefits were known of the high intensity statins. And, these trials were started by manufacturers. So I think a manufacturer was actually, ezetimibe at that time was branded. And so they developed a combined product. And I think they were trying to find a way to sell their drug. So, I think one of the other papers I showed today, the trial was developed in conjunction, although analyzed with the pharmaceutical, but was analyzed separately. But I think that that's part of the history of how trials get done. Yeah.
The primary care guidelines
Yeah, so the question was, the guidelines a few years back recommended just, high-risk patients put them on a high-intensity statin, and low-risk patients just put them on a moderate intensity and never check an LDL again. Those guidelines, if they haven't changed already, they're going to change because of the new evidence about the opportunity for intensification of treatment. So I think that that guideline was recommended when there were no other options to intensify treatment that were of benefit. Now we know that there's added benefit from adding ezetimibe. Now we know there's some segment of the population with established cardiovascular disease is going to benefit from a PCSK9 inhibitor. So I think there's a role to check LDL now. Jim.
Are there prior authorization requirements for the SGLT2s and the
GLP-1 agonist. So I can't speak for every plan. I can only speak for Providence Health Plan, and there are no prior auth requirements. So we do actually try to minimize provider burden. I don't think we're always successful. And sometimes I think when we get questions about when we're adding burden, if we can't justify it, we need to stop it. If we can justify it, we need to explain to people why we do it. So those were taken off about, it's over a year for SGLT2 inhibitors, and I think the GLP-1 agonists now off. Any other questions? All right, thank you. Thank you.